Welcome. Today we're diving into vascular anomalies. It's really crucial we're precise with our terminology here.
Absolutely. Getting the terms right, especially distinguishing hemangiomas from vascular malformations, is fundamental for diagnosis and, well, for management.
Couldn't agree more. So we'll touch on the main classifications, things like RISC-H, NICH, and AVMs.
Right. Let's start with hemangiomas.
Okay. The big take-home for hemangiomas, they involute, they shrink. So surgery often isn't needed.
Exactly. And we should focus particularly on infantile hemangiomas.
Yes. The most common benign vascular growths in infancy. You see them quite a bit, especially in preterm or low birth weight babies.
And slightly more often in girls. Head and neck is the most common spot, right?
That's right. Mostly single lesions, too. Diagnosis is usually clinical.
Primarily history and physical exam, yeah. If you
Mm.
need confirmation, a Doppler ultrasound can show that characteristic fast flow pattern.
And they have a pretty typical life cycle.
They do. It often starts subtle, maybe a pale spot, tiny red vessels, pinprick marks.
Then it progresses to that familiar bright red raised lesion.
Correct. After that initial growth, there's usually a quieter period before involution starts.
And that involution phase involves central fading, softening, flattening.
Shrinking, color lightening, becoming more fibrous. You might end up with some residual skin changes, maybe some atrophy.
So proliferative phase is roughly the first year, with most growth early on.
Yeah. Birth to about 12 months, and a lot of the size increase happens by 3 to 5 months.
Then the involution phase kicks in, from maybe 12 months up to 7, even 10 years.
That's the typical time frame: gradual shrinkage, fading, flattening.
And the involuted phase after age 10 might still leave some residual bulk or skin redundancy.
Often does. Maybe about half show some residual changes.
What predicts resolution? Is it size, location?
Interestingly, no. Initial size, sex, site, even really rapid early growth, none of that reliably predicts the final outcome. Even multiple lesions might resolve differently.
So it's really just about the timing of involution itself.
Pretty much. Ulceration is different, though. That impacts scarring, not the ultimate resolution.
Okay, so management. Often conservative, watch and wait.
Given the high rates of spontaneous involution, yes. A large percentage resolve significantly by school age.
But if treatment is needed, propranolol is a major player now.
Definitely. It's a beta blocker, works through a few mechanisms, blocks VEGF, affects the renin-angiotensin system, seems to encourage apoptosis and fat development within the lesion.
But you have to watch for side effects.
Of course. Bradycardia, hypotension, hypoglycemia are the key ones. Also potentially diarrhea, drowsiness. Needs careful monitoring, especially initially.
What about steroids?
Steroids, systemic or intralesional, can arrest growth during that proliferative phase, but they don't typically cause regression like propranolol can.
Systemic might be used if it's too large for injection.
Right, usually for a defined period, maybe 4 to 8 weeks during active growth.
And lasers. Pulse dye and DYAG.
Those are useful mainly for ulcerated lesions or tackling residual redness after involution.
Surgery is generally delayed.
Typically, yeah. Often until school age for psychological reasons, unless there are specific urgent indications during proliferation.
Such as?
Things like visual obstruction, big risk of amblyopia or anisometropia there,
Okay.
or nasolarynggeal obstruction, the so-called beard distribution, is a warning sign for potential subglottic involvement.
Airway risk.
Exactly. Or auditory canal obstruction causing hearing issues. Those need prompt attention.
And complications to be aware of. Bleeding.
Usually manageable with pressure. Ulceration happens in a small percentage.
Infection.
More common in oral or periomeatal locations.
What about Kasabach-Merritt?
That's a serious one, thrombocytopenia associated with specific vascular tumors like caposiform hemangioendothelioma, not usually infantile hemangiomas themselves.
Right. And high output heart failure.
Can happen with very large liver hemangiomas or widespread hemangiomatosis. Multiple neonatal hemangiomatosis also carries significant mortality risk.
Any others? Skeletal effects.
Yeah, pressure can sometimes cause skeletal distortion. And don't underestimate the emotional or psychological distress, especially around age 5 or so.
Good point. Are there specific associated disorders we should quickly mention?
Sure. Congenital hemangiomas, fully formed at birth. RACH involutes rapidly. NICH doesn't involute at all and might need surgery.
Okay.
Then you have syndromes like Maffucci's, von Hippel-Lindau, PHACE syndrome with large facial hemangiomas.
In caposiform hemangioendothelioma or tufted angioma, which you mentioned regarding Kasbach-Merritt.
Exactly. Locally aggressive can enlarge, then partially regress. Steroids or surgery might be needed.
Okay, let's switch gears to vascular malformations. Key difference. Present at birth, grow proportionally, don't regress.
That's the core distinction. They're structural anomalies from errors in embryonic vascular development.
And the autonomic nervous system plays a role. Explain some distributions.
Seems to, yeah. Particularly relevant for thinking about why port wine stains often follow trigeminal nerve distributions.
Let's talk about those capillary malformations or port wine stains. It's fairly common.
Seen in a small percentage of newborns, often on the face. And yes, the association with Sturge-Weber, if it's in the V1 or V2 trigeminal distribution, is key.
More common in girls again.
Seems so. Treatment is typically laser.
Photocoagulation, yeah. Pulse dye laser, sometimes ND.YAG. Multiple treatments are usually needed, especially for V2.
Combining laser with imicamod is another approach sometimes used.
And if it involves V1, an ophthalmology review is essential because of the glaucoma risk.
Definitely. Untreated, they can thicken and develop that cobblestone appearance over time.
And syndromes to remember here are Sturge-Weber, Klippel-Trenaunay.
And Parkes-Weber, which is similar to KT, but with an AV fistula component.
Okay. Moving to venous malformations.
These often present as blue or purple, sort of spongy lesions, characteristic swelling when dependent, and they deflate when elevated.
Patients might complain of aching.
Yes, especially in extremities. And they can be sensitive to hormonal changes.
Treatment options.
Sclerotherapy is common. Compression, NSAIDs, analgesics for limb pain, laser, maybe argon, or NDYAG, and sometimes surgical resection.
Complications like thrombosis.
Thrombosis within the malformation, yes. And sometimes localized intravascular coagulation issues.
Right. How about lymphatic malformations?
Often see clear cutaneous vesicles if there's a dermal part. They're typically soft, compressible. A key feature is they can cause bony overgrowth nearby.
And they often occurred with venous anomalies?
Frequently combined, yes. Histologically, you can get macrocystic or microcystic types or mixed.
Treatment involves sclerosing agents.
For macrocystic lesions, yes, injection works well there. Laser can ablate cutaneous blebs. Surgery is an option, as is compression. Steroids or antibiotics might be needed for inflammatory episodes.
What are the challenges with lymphatic malformations?
Infection is common. Surgery can be tricky too. Risk of prolonged drainage, slow healing, infection, and recurrence is quite high.
Okay, finally, arteriovenous malformations, AVMs, high flow lesions.
Correct. Direct artery-to-vein connections. You need imaging like angiography to understand the anatomy and hemodynamics, and MRI for the extent.
And they progress through clinical stages.
Yes, often described in stages. Stage 1, quiescent, might just be a warm pink or blue area.
Stage 2, expansion.
That's when you might feel a thrill, see dilated veins, pulsatile.
Stage 3, destruction.
Ulceration, necrosis, bleeding can occur then.
And stage 4, decompensation.
Cardiac issues, high output failure in severe cases.
Treatment is complex, often multimodal.
Very much so. Need to manage any coagulopathy first. Then preoperative embolization is standard, usually within about 72 hours before surgery.
To reduce bleeding.
Exactly. Surgery itself needs to be wide local excision because recurrence rates are high. Techniques like hypotensive anesthesia or even cardiopulmonary bypass might be needed for bleeding control in major cases.
And reconstruction afterwards.
It often requires flap reconstruction.
Major complications to watch for.
Consumptive coagulopathy, congestive heart failure, local tissue destruction from the AVM itself, and significant surgical bleeding.
And syndromes associated with AVMs.
Things like benign zona, Riley-Smith, blue rubber bleb-Nevis syndrome, and Osler-Weber-Rendu or HHT.
Okay, that's a lot to cover. Let's quickly recap the absolute key takeaways.
AVMs often need that pre-op embolization before surgery.
Hemangioma is common in infancy, usually involute spontaneously. Remember that 70% by 7 years figure is a rough guide.
Right. Treat hemangiomas non-surgically unless there are clear complications like bleeding, ulceration, or obstruction.
Vascular malformations present at birth don't regress, grow with the child.
Port wine stains commonly affect the trigeminal nerve distribution. Think Sturge-Weber.
Venous malformations swell dependently, might be hormone sensitive.
And lymphatic malformations can cause bony overgrowth. Watch for infection and surgical challenges.
Excellent summary. So the fundamental difference between hemangiomas and vascular malformations, and using that correct terminology, really is paramount for getting the diagnosis and management right.
It dictates everything that follows. Perhaps something for you, the listener, to consider is how ongoing research into the molecular pathways, the genetics and signaling involved in both hemangioma involution and malformation development is constantly reshaping how we approach these conditions, leading to potentially more targeted therapies in the future.
A great point to end on. Thanks for that comprehensive overview.